they couldn't see the slides properly. Okay. So I think I addressed why I've developed this interest in diarrhea, and it has to do with your quality of life and getting the right diagnosis so that you get the right treatment. And actually 30 to 50% of people with gastrointestinal or pancreatic neuroendocrine tumors have a non-endocrine cause of their diarrhea. So that's actually quite a lot of people that are affected. Well, I think a lot of you know what we mean by chronic diarrhea, but there is a definition, and one of them is that greater than 240 grams of stool a day, or loose motions greater than 3 times a day, lasting longer than 4 weeks. So not suggesting that you go out and start measuring your poo to make sure that you're getting over 240 grams a day. I think a practical greater than 3 or more times a day for longer than 4 weeks is enough of a definition of chronic diarrhea. And that and a loose motion is defined as a stool that's 5 to 7 on the Bristol stool chart. So someone in Bristol came up with this way of defining stool. So some of you might recognize your own stool type there. So we're talking about type 5, type 6, and type 7 as being, for our purposes, considered diarrhea type motions. So there are really a lot of different causes of diarrhea, and we're going to go through each of these different categories of the causes one by one. So I think, you know, the human body, as you all know, is so complicated. So it sometimes helps to try and sort of put common conditions together. So we've got secretory type diarrhea, malabsorptive type diarrhea, inflammatory diarrhea, and then there's a bunch of other causes. So secretory diarrhea is a common type of endocrine related, as in hormone related diarrhea, and it's based on the principle of osmosis. I think when I made this presentation, I think the rolly eyes are to maybe signify, I don't remember my thinking at the time because I made this presentation a couple of months ago, but I think it was because I think I was reminding you of going back to school and learning about osmosis in your science class. So if you remember osmosis, it has to do with water moving across a semi-permeable membrane. So we've got a membrane here down the middle that's got little gaps in it that won't allow these little orange or yellow, blobs to come through, but it does allow water to come through. So if we had water on one side, it will want to move across to where there's lots of other particles. So that is what is meant by osmosis. When we are talking about secretory diarrhea and osmosis, we're talking about what your body does to shift water from one part of your body to another part of the body. In this case, from the cells of your body into your intestines. So the water is moving from your body then to this other side, which is your intestinal lumen. So if you've got water moving in there, then that's how you will get a type of watery diarrhea. And this happens in, for example, carcinoid syndrome, but in other hormone-related types of diarrhea, because a hormone will bind to its receptor in the intestines. These include serotonin, like carcinoid syndrome, but also gastrin. Vasoactive intestinal peptide is another type of hormone, calcitonin. Once they bind to their receptor, that pushes chloride from inside the cell into the outside of the cell. And as I was talking about earlier with osmosis, because as the chloride goes across, water's going to follow with it because of osmosis. Now you're all wishing that you paid more attention in science class at school. I know some of you did. So when we're talking about secretory diarrhea, that's what we're talking about. We're talking about the type of diarrhea that's caused by the receptor, often serotonin and carcinoid syndrome, but there are other hormones that do it as well, bind into the receptor, pushing chloride out into the intestines, and then that chloride drags the water along with it. And the management for that, as many of you will know, is managing the underlying tumor. So ideally, we would like to remove the tumors by surgery, but sometimes people need treatment before surgery, and sometimes not all of the tumor can be removed by surgery. So that's when somatostatin analogs such as octreotide are important. With a particular type of hormone called gastrin, we can also treat those with the common medication some of you may be on for other reasons, called a proton pump inhibitor, such as omeprazole, which lowers the amount of acid in the stomach. So often when we're talking about neuroendocrine tumors and diarrhea, we're talking about, this is what we're talking about, secretory diarrhea. That doesn't mean that you can't have other causes as well. So maldigestive diarrhea, I think may have been alluded to in the previous presentation. So the whole working of our digestive tract relates to, we eat the food, and then the food has to get broken down into tiny, tiny little particles so that it can get absorbed into our body. And it gets broken down by enzymes represented here by the knife. And then our main sources of food are carbohydrates, such as bread, probably the best source of carbohydrate in my opinion. And then we've got proteins, such as meat, and then we've got fat. Those are our major sources of energy, and our body needs to break them down in order for us to be able to actually absorb them into our body. So we have all these enzymes floating around inside our stomach and our intestines that break down protein and break down fat. And then on the cells of our intestines, on the lining of the walls, we've got other enzymes that break down carbohydrate. So there's certain conditions, and you may have heard of them, such as celiac disease and lactose intolerance, where we lose these enzymes on the cells that break down carbohydrates, which means that the carbohydrate can't get absorbed by the body because it's too big. So we've still got the enzymes that break down protein, and we've got the enzymes that break down fat. So the fat and the protein can get absorbed, but the carbohydrates can't get broken down and they can't get absorbed. So just like I was explaining earlier about osmosis, if we've got all these particles, in this case carbohydrate particles in our guts, they're going to draw water along with them. And that's why if you're a lactose intolerant person and you have some lactose from a dairy source, you've got all that lactose that can't be broken down, that draws water with it. Similarly with celiac disease, you lose the ability to break down any carbohydrates, and you try and have some pasta, and then you'll soon know about it, some diarrhea later. Hopefully that principle of osmosis has made sense, because it is really key to understanding a lot of the different causes of diarrhea. You can have another problem that relates to enzymes, where you lose the enzymes that break down protein and break down fat. These enzymes come from the pancreas. So someone who has had a lot of their pancreas removed may not produce these enzymes anymore. Or someone who has got a blockage, maybe from a tumor that's stopping these enzymes getting out into the digestive tract, then they can also have problems breaking down the protein and the fat. And then the way that octreotide works, so octreotide works on lots of different receptors in the body. And one of the things that it can do is actually slow down the release of these enzymes into from the pancreas into the intestines. So you can sometimes have issues with not being able to break down the protein and the fat due to being on octreotide. And there's a very rare type of neuroendocrine tumor called a somatostatinoma, which is basically, the somatostatinoma is basically producing something very similar to octreotide. It's producing somatostatin, which octreotide is based on. So the effects that you get with octreotide, a somatostatinoma produces the same effects. So in this case, you can see the protein and the fat are still sitting in the guts. The carbohydrate can be broken down and absorbed, but all that protein and fat in the guts draws across the water into the guts because it can't be absorbed. So maldigestive diarrhea, the causes include pancreatic insufficiency, which can be due to a lot of things related to neuroendocrine tumors. So it can be related to being on octreotide treatment, having had your pancreas removed, having a blockage of the pancreas, and then very rarely this rare type of neuroendocrine tumor, somatostatinoma. So there's a lot of reasons why a person with a neuroendocrine tumor may not be getting enough of the pancreas enzymes. The next cause I'm going to talk about is inflammatory bowel disease. When you think about it, the insides of our intestines are kind of similar to the outside of our body in that they have to be fighting bacteria all the time. So every time we eat food, we get the normal everyday bacteria from the food goes down with it. But then also, I think probably most of you are aware that in our normal large intestines, it's just normal for bacteria to live there, and they're part of how the food gets broken down. And as long as it's good bacteria, then it's fine. So we have a lot of immune cells within our intestines, or all of from our mouth down to our anus. We've got a lot of immune cells to keep all those bacteria within our gut system in check. But just like what can happen with the immune system in a lot of places, the immune system can get out of control. And if the immune system gets out of control, it starts causing unnecessary inflammation within the cells. Those cells get damaged and break apart. So what happens in this case is that barrier between the lining of your intestines and the intestines gets broken apart, and water can just flow freely across, and you get diarrhea for that reason. So there's two main types of inflammatory bowel disease: Crohn's disease and ulcerative colitis. These conditions are not any way related to neuroendocrine tumors. So they're a totally different type of condition. However, just because you have one uncommon condition doesn't mean that you can't get another uncommon condition as well. So you're not very likely to have inflammatory bowel disease, but it is something to keep in mind. If you're having bloody diarrhea, if your diarrhea is quite mucousy, of course, a lot of you related to your neuroendocrine tumor related diarrhea will get abdominal cramps, and you can also get nocturnal diarrhea as well. But you wouldn't normally have fevers, and you shouldn't have blood or mucus in your diarrhea if it's just related to your neuroendocrine tumor. So that's definitely a sign that you need more investigation. So as I mentioned, it's unrelated to NETs, and just through bad luck, there's about an overlap in 1% of people. And then lastly, there's kind of a group of causes that are harder to put into a definite group. And I've divided those into ones that are related to treatment for neuroendocrine tumors and those that are unrelated to treatment for neuroendocrine tumors. So related to the treatment of neuroendocrine tumors is short bowel syndrome and small bacterial overgrowth. Then unrelated to neuroendocrine tumors, so things that you could just randomly get just as being unlucky as to get more than one condition. It's irritable bowel syndrome, hyperthyroidism, CVID is common variable immunodeficiency, not a very common condition. Neuroenteropathies, so this is when the nervous system that supplies the bowels is damaged. This can be caused by something like having diabetes for a very long time, and protein losing enteropathies. So I'm just going to talk a bit more about the short bowel syndrome and small intestinal bacterial overgrowth. Small bowel syndrome describes what you imagine. So if you have to have surgery to remove a neuroendocrine tumor, then you may have quite a large portion of bowel removed with it. And that's sometimes to do with, even if the tumor itself is not really big, if it's interfering with the blood supply and the blood vessels have to be removed, then the part of the bowel that is supplied by those blood vessels, that also has to be removed, because without its blood supply, that piece of bowel will not survive. So sometimes just in order to remove a tumor that's maybe a few centimeters, actually a longer length of bowel has to be removed. Everybody's bowels are a little bit different length, but the normal bowel is kind of around 6 meters, and short bowel symptoms tend to occur if you've got less than 2 meters left. So you have to have quite a lot of bowel removed to get short bowel symptoms, and surgeons are very wary about moving too much bowel. So they will usually try to avoid having to remove this much bowel, but sometimes things happen, like a tumor that's obstructing and has to be removed, where people could end up in this type of situation. So what that means is that there's just a shorter length of bowel, shorter length for water to be absorbed into the bowel, and so sort of food, water, anything that you take in by mouth just sort of runs more quickly through the system. Small intestinal bacterial overgrowth, I think is something, it was definitely something that I was not looking out for before, and I think perhaps is something that we've underdiagnosed. As I mentioned before, it's normal for the large intestine to have bacteria in it. Bacteria is part of what helps break down fiber, and also those bacteria, they make some vitamins. So that's why we call them the good bacteria, because they're good for our body. Small intestines, it's not normal for bacteria to be there. So when the bacteria are in the small intestine, they can interfere with the function of the normal intestine. So they interfere with nutrients being absorbed by the small intestine. So as I mentioned earlier, do I have another picture that goes with that? Oh, sorry, I've just got disconnected from So when you've got bacteria in the small intestines, they break down the nutrients that you want to be absorbing. The bacteria starts using those nutrients. So that means that if you have this problem, you're not getting all the nutrients that you need. But also, because the bacteria are sitting there breaking down the particles, you end up with more particles within the small bowel. And as I've mentioned many times before, when you've got more particles, just more stuff you have there, the more water gets drawn into the intestines, the more watery, and then you get diarrhea. So how could this be relevant to you? So if you are someone who suffers from diarrhea, you could be someone who has an endocrine cause, as in a hormone cause, or you could be someone who has a hormone cause and has another sort of cause that's related to neuroendocrine tumor treatment, or you could be someone who has hormone-related diarrhea, but also has one of those other causes that I mentioned that have no connection to neuroendocrine tumors. Or perhaps the diarrhea in your case is actually due to something unrelated to a neuroendocrine tumor. And basically, you can have more than one cause of diarrhea, and that's actually very common in people with neuroendocrine tumors. So I've discovered in the past year, it's actually quite common to have more than one cause. So if your diarrhea is not controlled with the treatment for neuroendocrine tumors, so often that would be octreotide. So if octreotide has made no difference to your diarrhea or hasn't improved it, you may also have another cause of your diarrhea as well. So this is just kind of blowing up that picture so you can see more easily, but I think I've explained that already. So you can have more than one cause, and you can have causes that relate to the complications of neuroendocrine tumor treatment, not just due to neuroendocrine tumors themselves, but on the odd occasion, a person is unlucky enough to have more than one unrelated condition. So, so what can you do about this now that I've told you maybe your diarrhea is not endocrine related? Is there any way we can try and work that out? So there's some investigations that we can do, which would involve collecting poo, including testing your poo for the enzymes that I was talking about earlier, the enzymes that break down protein and fat, testing your poo for signs of inflammation, testing your poo for blood. So as I mentioned with endocrine hormone-related diarrhea, you should not have blood in your poo. And you can test the osmolality of the poo. So you can test how watery, how much of that runny poo stuff is related to, you know, how much water is in the poo. So this, I just wanted to show the slide again, just to show that, you know, there are lots of different causes of diarrhea. So if, you know, perhaps you've got carcinoid syndrome, but your diarrhea is not under control, or if you've had surgery on your pancreas, then there may be another cause should be considered as well. So perhaps I'll leave that slide up there. I see, how common is it to have a NET without diarrhea? Yeah, it's it really depends on what neuroendocrine tumor you have. So while diarrhea is a very common symptom amongst people who have gastrointestinal pancreas neuroendocrine tumors, but certainly doesn't happen for everybody. And then for the neuroendocrine tumors that do not occur within the gastrointestinal system, so ones that occur in the lung or the thyroid or the adrenals, then it's very uncommon to have diarrhea-related neuroendocrine tumors. Yeah, so I guess once again, it depends. It depends on what type of neuroendocrine tumor you have, but non-functional neuroendocrine tumors are the most common. So overall, the most common thing is not to have, overall, if you put everyone together, most people do not have diarrhea. Having said that, for people with NETs, diarrhea is the most common symptom. I think the way that I said that was really confusing. Diarrhea is the most common symptom of people with neuroendocrine tumors when you put it together as one single symptom. But still, the majority of people, diarrhea is not the issue with their neuroendocrine tumor. A lot of people have what we call non-functional neuroendocrine tumors. I think I've asked that question in a very confusing way. So there's a question, do you need to have certain markers for carcinoid syndrome for octreotide to help? Yeah, that's a tricky, it's a tricky one to answer directly. If you do not have, so the marker that we test for carcinoid syndrome is a urine test, a 24-hour urine 5-HIAA, and we are in that case looking for serotonin, which is one of the causes of diarrhea. If you have diarrhea and an elevated 5-HIAA, then octreotide should help you. But serotonin is not the only compound that can cause carcinoid syndrome. So there are other compounds that are harder for us to measure. Histamine is one of them, but there are a few others as well that also cause diarrhea, and they will not be picked up by that 5-HIAA test. So just because you have the negative marker doesn't mean that octreotide won't help you. And then on the flip side of that, if you have diarrhea, but your 24-hour urine 5-HIAA is normal, I would really want to investigate you for the other potential causes that I've discussed to make sure that you are actually on the right treatment for your diarrhea. Hopefully that answered your question, Elise. So you can still get benefit from octreotide even if you don't have an elevated 5-HIAA, which is the marker. But you also want to be careful that you've actually made the right diagnosis if your 5-HIAA is normal. Were there any other questions?
Veronica, that's been absolutely awesome. I think you can all see why Veronica is the diarrhea legend, and it's you know, this is not the first time I've heard that talk, as she mentioned, but I just pick up on details each time, and I think it's been a really interesting afternoon, you know, starting with Police's experience of NETs and the diarrhea before even diagnosis, and the you know, the uncomfortable difficulty of it all, you know, to some top tips and dietary assistance and management, but actually understanding what's going on. There's just nothing better, is there? You know, understanding why that happens. I think that's, you know, we've got a really sophisticated group of unicorns who know a lot about their conditions, and you know, this is a perfect talk for for people to get their head around. Good old osmosis and why it makes a difference in diarrhea now.
I know all those things that you learn when you're a teenager, and you're like, when is osmosis ever going to be relevant to my life? Well, osmosis is very relevant to life. I think it's very, I think like we've talked about before, Michelle, that I think when you get diagnosed with a NET, I think clinicians, we can get quite tunnel visioned as well about once a diagnosis is made, such as having a neuroendocrine tumor. We just don't always, we stop to think outside the box. So I think that's definitely something that I've, in relation to diarrhea, that because meeting so many of you is actually, it's informed me a lot about what areas are we not really dealing with very well. And this was a major area that I felt, we're actually really not doing you guys the best service that we could. So hopefully that changes in the future and more of you get symptom control from your diarrhea, because I know it impacts the quality of life for a lot of you.
Yeah, and look, thank you so much for this talk and your time. And the thing that we definitely want to pick up on, Olivia popped up in one of her slides, was the food and symptom diary that's on Neuroendocrine Cancer Australia's website. And we really want, we'll just go and I think adapt that and chat to people like you, Veronica, and others about what kind of, what's the most useful information we can make sure we've got on a symptom diary, and we'll get one of those up onto our website and pop it in the patient page, because I think, that's the kind of thing, look, you see it with all the COVID tracing, right? You can't actually remember what you were doing 2 weeks ago or what was different about that day compared to other days. So we think that will be a really helpful tool that we can, arm patients with, so that when they come to you, or anyone else like you, they can actually see, you will have a better view of what the symptoms are and how they're tracking.
Yeah, I think that's a great idea. I think a couple of people are starting to do that. And I think it is very hard to keep a very detailed food diary. It's not something that most of us have the time or energy for, to, like 365 days a year. But I think if you can do a period of time, like say a week, where you keep a really close record, then I think it will. I think we still, kind of a lot of things we don't know. We don't fully have the picture. Dietary stuff is so individual that I think that'd be a great idea to start keeping a record of food diaries. I like it. I would like to see more. I'll be happy to look at your food diaries. I can't promise that anyone else will be interested. You can bring your food diaries to me. I'll look at them.
Fantastic. Hey, look, Veronica, I know that everyone is so grateful to you just like peeling back the onion on diarrhea and giving us this great primer and this great understanding. Thank you so much for your time. We really appreciate it, especially as I know how busy you are.
No trouble at all. My pleasure. I'll see you later then.